So I think the next few years are going to continue to be full of excitement in the field of multiple myeloma to the greater benefit of our patients. We're seeing immunotherapy revolution with monoclonal antibodies, now CAR T cell, and very soon bispecific antibodies, in addition to other class of agents. CAR T cell, is on itself revolutionary. Seeing the depth and duration of responses that we're seeing in triple class refractory patients is absolutely amazing, and I think we all want to see how that therapy performs in earlier lines of therapy. CAR T cell probably is going to always have an access and affordability challenge that I think is really at least as big as the scientific and clinical challenge. Nevertheless, that's where most of the excitement is. And I'm very interested in seeing the bispecific antibodies. They have shown preliminary, at least the BCMA target ones have very exciting preliminary data in the triple class refractory population. They tend to have a very acceptable toxicity profile, even though that is a difficult population to work with. So they are very amenable to combinations. So I'm really interested in seeing how they combine with monoclonal antibodies, with immunomodulatory agents, and how they can be deployed in earlier lines of therapy, in early relapses, or even the newly diagnosed setting. Their potency is very clear, and the opportunity of leverage from less heavily impaired T cells, as you expected to see in early phases of the disease, it's really very attractive, and can be one of the multiple incremental steps towards a cure for multiple myeloma. There are, of course, other agents that are in the horizon that is exciting. I think Selinexor has, particularly with lower, less frequent dosing, in combination with proteasome inhibitors, is very attractive, maybe a good opportunity in some subset of patients, particularly high-risk patients with high-risk disease. I'm very interested in seeing further development of Venetoclax on 11-14 myeloma. I think we will eventually find a patient population with 11-14 where that therapy can be, life-altering. And of course, I think, without the new classes of agents and immunotherapy that we've seen in the past few years, the alkylating agents were left besides almost limited to the high-dose therapy and transplant setting. And it's not uncommon that I see patients have had 4 or 5 lines of therapy and have never received an alkylator, which is nevertheless an active class of drugs. So I'm interested in seeing how Melflufen develops by being essentially a new and very intriguing delivery system for a very validated class of agents. I think there is an opportunity to explore that agent in later lines of therapy, particularly as we move immunotherapy and IMiDs and PIs to earlier lines. I would really like to see combinations with that agent.